Thank you very much for inviting us here from North Shore University Hospital to present to you today. This topic is really important because improving performance and defining value at a large tertiary hospital in a competitive landscape is challenging. There are many competing priorities for CEOs that they face. It could be pay for performance, what the public reporting ratings show, never events, meeting budget targets, worrying about operational performance, compliance with standards, evidence-based care. It could be survival, mortality, readmissions, lowering infection rate, you name it. We all have to deal with it. In our case, we also have a new building going up and we're designing new services. We're also looking to see what data and what databases are useful for us to make decisions. At the same time, we have to build relationships internally and externally and make sure our communication is sound to our stakeholders. So today's webinar, we're going to talk about the role of quality and safety for hospital administration from a CEO's point of view with my boss, John Sendach, who's the executive director here at North Shore, and a former senior vice president of quality and now trustee, Dr. Yosef Dlugacz. We are delighted to share and demonstrate how quality management principles are structured and operationalized here at North Shore University Hospital.
Good morning. The form of this presentation will be in the form of an interview. It's really a great pleasure to have the CEO of North Shore University Hospital with us today. And at a hospital that is part of the Northwell Health System. John, if you don't mind, would you explain to the audience the scope of North Shore University Hospital within the Northwell Health System?
Sure, and really happy to be here. So I'm John Sendach. I'm the executive director at North Shore University Hospital, one of 23 hospitals that comprise Northwell Health, New York State's largest health system and its largest private employer. North Shore University Hospital is both the original hospital of the system. As the system was growing over 25 or 30 years, it sort of began at this institution. And it's also the physically largest. It's a 850 some odd bed academic medical center that provides quaternary level services, which certainly includes solid organ transplantation, a level 1 trauma center, and many of the other programs that you would have. And so as we kind of switch to the next slide, you'll see some of the facts and figures about North Shore University Hospital. It's large from a standpoint of the number of employees that are here, about 6,000 people, of which about 2,000 of them are nurses. 53,000 discharges in 2019 data, as you can see, and an emergency department that sees between 80 and 90,000 patients a year. From a financial standpoint, total revenues, and this number is a little bit outdated, is up to about $1.8 billion a year. And as I noted, it covers a service area that's extremely dense. This is the New York metropolitan area. This hospital sits about 1.5 miles outside of the New York City boundary, and provides services to very densely populated suburban counties with several million people. I'll let the facts and the figures, so to speak, for themselves, but that just gives you, I think, a sense of the size and the breadth of this institution.
Yeah, the growth of this system and the evolution of the medical care that you have in this organization forced you to look at the whole process of care, not only from the point of view of utilization, to get patient, to make revenue, but you really focused in terms of the budget on value.
Yeah.
Could you a little bit tell us, before you go into your strategy, what value means to you in this evolutionary change?
Yeah, and I think that's a really important statement. It's not about doing a lot of things. It's about doing a number of things well. And I think how you evaluate the degree to which you're providing reliably and consistently good programs is something that I think is important to all executives. I think we all sort of strive for that. we weren't able to achieve growth the way we have at this institution over the last at least 10 years since I've been here, exclusively on the backs of volume. It's absolutely an element of being able to determine that we're providing value not only to the communities but to those who pay for the care. And to do that, you have to be able to measure your results, and you have to be able to get outside validation that your programs are thriving at the right levels. And if you think about a lot of the bigger programs, whether it's organ transplantation or whether it's cardiovascular procedures, whether it's cancer, the American College of Surgeons verification process for level 1 trauma centers, all these things require outside validators from elsewhere in the country to come in, look at what you're doing. And one of the things they want to see is the data. That's and that I think is going to increasingly be true. I think that's what gives you the ability to say we're reliably demonstrating consistency, and we're able to deliver care at a particularly high level. And I think when you do that, that enhances reputation. I think with reputation comes market growth. That's kind of how we've looked at it.
It's very interesting because you raised a very important issue, and that is the role of data. So do you feel that the new executive of today's hospital needs to be a little bit more savvy with data and all the understanding of quality and analysis before they go to the budget, for example?
Yeah, I think it's definitely the case. And as you, Dr. Dlugacz, know, and Andrea certainly knows, when I did my administrative fellowship about 18 years ago, I had the good fortune of spending time in a number of different areas. Quality was one of them. You two were both there at the time. And I think the foundational elements of how CEOs or people who thrive to be hospital executives grow is understanding the intricacies and the components of things that are data oriented. I ended up going into finance when I left fellowship and spent a number of years as a finance executive before ending up in the top spot. But I think what ends up happening is that through whether it's a financial lens, whether it's a human capital lens, whether it's traditional quality metrics like infection control and infection prevention and infection rates, I think what ends up happening is that the people that I think will continue to emerge into the senior levels of positions in hospitals must be able to review, interpret, and understand what data is telling them, because that's what we're looking at in terms of employee engagement scores, turnover rates, customer experience scores. Everything we do now has some metric, and we've sent endless numbers of scorecards, and we're asking people to manage those scorecards. You have to be savvy with data. I don't think you can do it by gut.
Very good. Thank you very much.
Sure.
The next area of interest is that what is the strategy of North Shore University Hospital?
Yeah, it's a great question. We have a certain responsibility. We are the sort of the largest hospital in this region, and we're the only hospital that provides certain programs. So in our larger service area, going out, almost 70 or 80 miles to our east, we're the only medical center that provides liver, heart, and lung transplantation. So that puts us in an interesting, kind of area of responsibility that it's important for us to be able to deliver on services consistently and reliably. And while there's many great hospitals around us, some that are part of our system, others that are not, we still have a responsibility to some communities to provide certain things that other places don't. So we've kind of broken that down, as you see on this slide, into what I like to look at as these 4 pillars. Everybody has buckets of goals. I find it easiest to look at it in these 4 areas. The 4 things that to me are most important for a medical center of this size, and that I think are consumable and digestible by staff, are these 4 areas. It's not too esoteric. People can understand the idea of community, reputation, growth, and sophistication. And everybody who works with me on the executive level, and even several levels down, can speak about that in a kind of detailed way. But what we kind of did was we created these verbal snapshots of ways in which we can explain what we mean by these 4 things in a way that staff are able to understand it, because alignment is very important. I think people want to understand where they're going. I think when people come to work, they want to understand, is this just something I do for 8 or 12 hours and I go home? Or what's the larger plan? And you have to be able to take what you would talk about in the boardroom, and you have to be able to distill it down, I think, to the people that actually do the work. And so what we've done is taken these 4 things and said, these are the 4 large bucketed areas we're going to work on, and every initiative we do here ought to be able to tie to one of them. And I tell people, if you're not able to keep your finger touching one of these 4 areas while you're doing some work, you can't relate something you're working on to one of these 4 areas, then in my estimation, you shouldn't be working on it. It's inconsistent with what we're focused on. Now, within each of these, we've got probably hundreds and hundreds and hundreds of initiatives across so many departments. But everybody, when they present on them, when they make a PowerPoint slide on them, is able to tie them back to at least one of these. Now, in some cases, you may have 4 of them, but I think that for us, it's been very helpful to help people understand the expectation. And so for us, community, which we explain there on the slide, I won't read it to everybody, represents who is our community. It's both the people that work here and our patients, but it's also those who live within X number of miles of the hospital. We're a community institution. We're a not-for-profit organization. We have certain obligations. Reputation to me is all about external validation. What do people think about it? Is that a good place? Is that not a good place? Some of that seems sort of subjective, but I think when you get external agencies to come in and validate you and issue you ratings, rankings, disease-specific certifications with the Joint Commission, you're getting people to come in and externally validate you. And I think less than a marketing ploy, reputation to me is all about what do people say about you in their places of worship, on the sidelines of their kids' soccer game. What do they think about your institution when they hear the name? Growth obviously is important to our overall survival. I think that's an important and somewhat obvious element. And then sophistication. And by sophistication, I mean people's appreciation for doing things in a way that seems very legitimate, that there's a lot of thought that went into it. You think about a sophisticated presentation of food in a fine restaurant, it's the same ingredients, but presented in a way that someone put a lot of thought into it. And we ask people, whatever you're doing, whatever you're working on, don't just do it with sophistication. So those are the 4 areas from a strategy that we've been focused on. So instead of saying our strategy is we're going to start X program in 3 years, we're really trying to keep people focused on a higher level of here are the 4 things we always want to be kind of driving at. Because I think if you continue to excel in these 4 areas through whatever metrics you tie to them, in a big organization like this, I think it keeps bringing the game up. And that's kind of been my thinking on this and our thinking on this.
It sounds, I'd like to make 2 points. One is that I was very impressed with the fact that you said that employees who come to work, they don't come to work to do a job because there is much larger, the role is larger than that. And what is the relationship? And I recall a while back when I did rounds with you once, senior staff, you talked to employees who clean the floors.
Of course.
At the time, I remember, and so they understood that cleaning the floor has to do with infection.
100%.
I'll never forget it.
Mm-hmm.
I think it's a wonderful scenario. The other thing is that it sounds like that what really underlines this strategy is that you are developing a culture of safety and quality and a robust process for improvement. Because you said you always try to figure out how to change and to make it workable, etc. Mm-hmm. So could you make a comment on that? Yeah,
I think you have to constantly be evolving. As you noted about what we say to staff, you have to keep in mind that, and I know you all instinctively know this. Everybody wants to feel like they're included. We talk a lot about inclusion in our organization. We talk about diversity, equity, and how people feel, whether they're in or out. Mm-hmm. In the elementary school cafeteria, there's always tension among kids who feel like they're not part of the cool kids team, right? And so when you go around and you talk about safety, and you go around and you talk about quality metrics, if you stop and talk to the PAs and the nurses, but you exclude, even in your huddle, other members of staff, including folks who answer the phone on a particular nursing unit, or you noted about folks who are responsible for cleanliness around the building, through your actions, you're excluding them. It's not meant to be offensive. It's not deliberate. In some ways, you could argue you don't want to take up their time. They're busy. You're just going to focus on the nursing team. But what I've found is that people just want to feel like they're part of the team. When people want to feel as though they're all wearing the same uniform. And so visual cues that executives have where they are deliberate about including people in those discussions, you bring them under the tent. And I think you always want, if you can, as many people under the tent as possible, feeling like it's their responsibility, feeling like they're part of it. And And then, yes, if you can tie specific actions they take to make them feel part of it, that's great. But what I've even found is that when I stop and talk to people, let's say on a nursing unit, as you described, I'm very deliberate about if I see people hanging around the periphery, saying, why don't you come over and join us? You know, because I think people feel funny about, oh, that he's just here to see the nurses, or he just wants to talk to the surgeons, or he just wants to thank the residents, and I think that, you know, we all have an obligation to think about how would you feel if you were standing in that crowd and somebody came up to talk to everybody, even if it's none of your business, you're not part of, you work on the unit, some way or another, you're part of it, and we should figure out a way to ask people to step over and be part of that. So I think that's all part of how this evolution will continue to happen in getting more people engaged in what we do. Because what we did learn through the COVID pandemic, which I thought was very interesting, was that staff told me that one of the things we were in a meeting about diversity and inclusion, and the employees said, you know, the time we all felt most together here was in the first wave of the COVID pandemic, because for a period of time we had everybody wearing scrubs. We at that time, you probably remember, didn't know whether this thing was being transmitted on people's clothing or whatever. So we were letting everybody put OR scrubs on when they first came into work, no matter where they worked in the building. So no matter who you were, if you were at work and not sent home, you were wearing the exact same outfit. And people described to me, because they had masks on and because it was hard to tell who was who, that everybody got treated much more similarly than in a normal scenario where doctors wear a lab coat and nurses wear white scrubs and ancillary staff or nursing assistants wear blue scrubs and the people that clean wear a different uniform. And once they all looked exactly the same, they said, you'd be surprised how many times people who traditionally didn't help clean something up were quick to clean something up. And I thought that was extremely interesting. I thought that dynamic of how people it's funny how people just want to feel like they're on the same exact team, and that, you know, while everyone likes their own identity, when you put everybody together, they start to work together. It was a very interesting, totally non-scientific social exercise that happened, but it was interesting.
Very interesting, because what you are raising, another thing in terms of the role of the CEO, not only he or she need to understand the quality principles and data and so on, but they need to be part of the hospital. They cannot sit in their C-suite and be with a closed door and be removed.
Yeah, I mean,
I need to be completely.
I agree.
It sounds like on the floor, integrated in the process.
Yeah, and I'll be honest with you, I admire the employees of this institution who are actually very vocal about that when we're not doing that enough. You know, I spent some time on the night shift here. I've been doing it once a week for the last 6 or 8 weeks, and I'm trying not to do it as part of a public relations campaign. I'm trying to do it very deliberately. But as I walk around the middle of the night, what I realize is it's been at least a year since I've done that. A lot of our more junior folks work on the overnight shift. A lot of them are relatively new, and I'm walking around saying, you know, I've never met you, and I apologize. And it's not their fault. They're at work on their shift. It's my fault because I don't happen to be around at night. Yet a third of our employees work that shift, and so, you know, I think, and they've been vocal as you know, a few of them are like, yeah, we have no idea who you are. And you have to be willing to take a little bit of that heat and recognize that, you know, that's part of my responsibility. And our entire team's responsibility. And it can't just be, you know, the last Thursday of every month, it's rounds time and we all come around like the ice cream truck. And if you happen not to be there when the ice cream truck comes, you never meet the people. So we're trying to be a lot more deliberate about doing it much more frequently and doing it at random repetitive times so that we meet as many people as possible. We think the time is, you know, going to be worth it. It helps more people feel like they're part of it. It's good for staff engagement, and we can already tell there's a dramatic change since we've started doing it. A lot of work for somebody like me, but I think that if you're going to take jobs at this level, my personal philosophy is you should be prepared to work really hard. I just think that's part of it.
So all of those experience that you just shared with us, which is really beautiful. I understand that your hospital produces a dashboard. And this dashboard, for you, it creates accountability to your value and the value of the organization and to data use. Do you mind to brief us on it?
Yeah, and it is up on the screen. And so, you know, again, we try and break metrics down that we think are easily presentable. And we use a very traditional, you know, PDSA improvement cycle, you know, which was taught in the quality textbooks, you know, when I was in graduate school and continues to be an important way of thinking about this, which is we monitor a number of metrics in a number of different areas. Obviously, quality is part of it, efficiency. We'll call this, people. And then we think about what are kind of the results looking like? What are trends that are they an outcome that we're seeing today only, or are they part of a trend? Just like in a medical record, you look to trend out someone's blood pressure, you look to trend out somebody's lab values to see whether this is a one-off, a trend. Compared to the previous time we reported, is that getting better or worse? And then we try and target areas that we think we need to put some kind of an improvement plan around. And then, of course, we challenge each other to look at that and to see how we're doing vis-a-vis that improvement plan. We use a variety of ways, just like I'm sure most institutions do, to do process improvement planning. But I think the most important part of this is, because our talk today is about leadership and less about how you do this, is what questions is someone like me asking about this? So is it enough to say, oh, yeah, we have a dashboard? Or do I periodically pick a couple of these metrics and start calling people and asking them about it? Because once I pick up the phone and start calling people and asking people about it, even just one of these, even if they don't know the answer, they know I'm looking at it. And that is an accountability tool that's very important for people at senior level. Otherwise, these types of dashboards can become just something like medical alarms. If you're not doing something about them and they go off all the time, people just don't want to listen to them anymore. And so I think that's how we kind of treat these sorts of things. But much like I tell our teams as it relates to employee engagement scores, that's our scorecard. That's what our workforce thinks about us. And so we have to recognize that who we ask questions about that and the degree to which we push on it a little bit is really important. And so that's to me why I think these dashboards can be extraordinarily valuable. I personally don't need to know everything about every one of these metrics. I don't need to know how they all work. It should work out that there's people that do, but my responsibility is, if we've decided that these are the ones that we're going to track, I should be asking questions about them and understanding what barriers we have to achieving green dots on as many of these as possible.
One of the matrices which is very interesting is, of course, the readmission that everybody's talking about.
Mm-hmm.
And I know that you and your team put an amazing effort in North Shore University Hospital in terms of understanding what it means to be readmitted. You developed a very big process to access the caregiver into the community.
Mm-hmm.
You monitor the people who are coming back and define the reason. Mm-hmm. And you have a very sophisticated community computerized center. Would you like to make a comment on it?
Yeah, I can take credit for none of what you described, although I do like your choice of word sophisticated, because what I'm interested in is that whatever we do in this space, it is in fact sophisticated. And what we ended up with is getting the right people to sit and talk about, breaking down what are the primary reasons people are coming back and how much of that is related to us making sure that there's a net to catch these folks as they leave the hospital. And fortunately, we work in an organization that has deep resources out in our community and has the ability to take care of patients remotely from home, continue to check in on them, follow up with them. We can deploy nurse practitioners out in the field. We can, pardon me, for certain programs that are particularly high risk, we can send people equipment that they can put in their house these days, and they can check in with us through a video chat and a quick vital sign check. A place for patients to call if they have questions so that they don't feel like the only thing to do is to run back because they can't get their doctor on the phone on a Friday night. And then most notably, trying to clean up all of the various reasons why people who leave here run into something when they go home and aren't sure what to do other than to just come back. And some of that is caregiver support, just social needs, that hospitals have to recognize is now their responsibility. I think the change about the government and others focusing on readmissions is it's not enough to take care of the patient through their episodic care. You need to spend your resources to make sure you have a way of preventing people from coming back unnecessarily just because you didn't have a good system in place to manage it. And I think we've done a fairly good job at addressing many of those things. Again, complex medical center. This would be easier in many ways if we were 150 beds that did a small subsection of medicine and some very straightforward surgery. So we can sometimes stand back and go, oh, come on, you know, it's hard here, patients are very sick, you know, like we all do in healthcare, we'll come up with reasons to explain away why our performance isn't where we want. What we're trying to do, and what we try and do here is to say, let's be sophisticated. What would be an ideal way of trying to design this? What's the right thing to do? And then figure out how to do it. Now, look, there's financial constraints on some things. Sometimes some of our solutions are just unmanageable and become across scale would work, but are way too expensive. But I think we found a lot of good medium here on finding things that work.
Right. And I know that you're going to talk, the next slide talks about sophistication. And
I love sophistication.
but one of it is that in terms of readmission, it's such a big issue nationwide that in cardiology, which is a service line that you created, which is multidisciplinary, now they do have a special program to follow patients with heart failure, which is a terrible disease, very complicated for, especially for geriatric patients. You develop a program here to follow those patients and send physicians to visit them at home and to check on them rather than bring them here to the hospital. Yeah. Which is a very interesting process because here you don't think about the money because you have to invest in this program a lot. And in the budget, you may even be in the red because of the in quality management, need to put additional resources to monitor all of this complicated process and get your results. 100%. So you'd like to make a comment?
Well, the comment really is exactly what you kind of noted. There's always going to be a tension between, you know, what we can afford and what the right thing to do is. But I think I'll keep going back to the pillars that we kind of focus on, which is if you deliver things in a sophisticated way and you're able to replicate your processes reliably, I think that puts you in a position where reputationally you become the organization of choice for patients. You know, the best from a purely clinical standpoint, it's clear to us that the best thing to do, and this isn't news to anybody who's watching today's webinar, that the best thing to do is to evaluate patients at home. You're particularly as follow-up, you know, it's particularly for older folks who find it hard to come out. That is this idea of trying to put the patient at the center. A lot of places talk about that, but the moment that you have somebody have to then get a ride from an ambulance company to come back to their doctor's appointment, you're not really putting them at the center. Certainly it would be far easier, wouldn't it, to put, you know, medical staff in a vehicle, even if you had to have a driver drive them around and to run them over to everybody's house and have the follow-up stuff. But logistically challenging, certainly higher costs. And the reimbursement systems aren't necessarily designed to reward you necessarily for doing that. But I think we have to balance which of the patient populations that makes the most sense for, which of our marquee programs does that make the most sense for, and how do you begin to do it, learn from it, check it, as we talked about PDSA, and then scale it. So at some point you recognize that there's some of these things you can do at scale, and then you just start doing it. You know, part of that boils down to, does the doctor who goes and follows up with some of these patients have to come out of the same department, or can you begin to train doctor at home type physicians and make sure they're familiar with all these patient populations and then leverage this one or two people as opposed to letting each department try and solve this for themselves. So I think those are some of the elements that we're looking at, but it's not new concepts, I think is the bigger point. And what we've just been trying to do is find new elegant ways to solve old problems.
I agree with you that the concept may not be new, but the implementation is
100%.
And it's very difficult to think even like this because based on our conversation, I came to realize that the CEO also needs to start to figure out how to invest in the future. It's not only in terms of meeting the budget every month, but to understand the medical care that is responsible, she is responsible for, and how to invest in, take into account different variables to make it worthwhile and to make sure that this will be the future. Yeah. That eventually you'll be making money.
100%. Like any other business investment, you have to try to hedge on where you think the market's going and try to invest in the things that you think are going to be the commodities of the future. And I think that's the best way to look at it.
So in the next,
I know we have about 10 minutes left.
Yeah. So in terms of sophistication, you did speak about sophistication, and you don't have to dwell too much on it.
Yeah.
And, I know that you talked about the different pillars, and, and also the access to the community is becoming also a very big issue in terms of your sophistication, and it's quite impressive. So we don't have to dwell on it. And
yeah, the only comment I want to talk about with community, because I do think that it's important, is that, and we have it, here on this slide, is that, we just have to recognize, particularly being in a hospital in an area that's, fairly urban and metropolitan, that the diversity of the patient populations are pretty significant. And, as an organization, we have to understand that community, and it's not enough to say, oh, we're gonna have a community relations team, and we're gonna have somebody at the hospital that does outreach into certain communities. You actually have to go out and meet community leaders and spend time understanding what the health needs are. And I think that's a lesson I learned in the last year pretty clearly. And we're early on in the journey of me personally being out talking to community leaders, but it's been some of the most rewarding work I've gotten to do, because there's just so much about what's important in other communities to their health needs. And we tend to, again, in our organizations, look at this exclusively as episodic care, meaning, oh, when that person comes in, do they have certain traditions that are important? But the simple fact of the matter is that there's a lot more to this, in terms of recognizing, I think we have to recognize that you have to understand what are the health needs of their community. And what we find out is that there's a lot of just non-hospital-related wellness work that communities are craving, that as we've come to understand it, look, we're not gonna be able to come in and solve all of the social needs in communities. We're not gonna be able to solve all the health and wellness needs, but we have to start to at least know what they are and try and figure out what resources do we have available that can continue to help and forge those relationships. So again, those community leaders reputationally see our institution as a place that is reaching out to them, focused on them, and thinking about them.
And the last comment is the results, of course, and this is the reputation and outcome.
Yes.
That you.
Yeah, I alluded to earlier. Yeah, yeah, and this, look, as I said earlier, I think the external validation is very important. It's easy for us to be a bit nationalistic, I'll call it, about ourselves and talk about how great we are, and build excitement pride among medical staff and employees around how terrific. But I think there is a value proposition, and again, not for marketing purposes. I don't like to look at this stuff as the sort of good housekeeping stamp of approval on a product, but I think just for us as leaders, for our board members, for people to feel that, to be assured that there's some legitimacy to our claims and to what we think we're doing. And so I think every one of our colleagues in this webinar would be able to put up a slide that has all this external validation. And I think we just look at it as not that we're doing better or worse than anybody else, but that we think taking the time and making the investment in whatever the data extractors are and the registrars that you need to participate in some of these programs, to just recognize that there's value in having external organizations who are comparing you to a data set of other hospitals in the nation are saying, all right, well, compared to your peers, here's how you appear to be doing. I think for us, and then I like the learnings. I like when they come and they report on time here and they say, you know what, we've seen this done really well at another hospital in Washington, D.C. You may want to consider looking at it this way. And I think, all of a sudden, all of our eyes open up. I think just sometimes those external validators is really important. And so that's why I show it here.
Yeah, and this is all illustrated in the next slide when you talk about engaged teams of people to be our targets.
Yeah, yeah, and I think we'll see that slide here in a second. But yeah, we talked about this, a little bit earlier about employee engagement. People want to know what they're doing when they come to work, and yeah, I often tell the staff here that this place is what it is because of the people who work here. During orientation, I joke with all new employees. I ask them, why is the reputation here good? How many of you were waiting a long time to get a job here? What's the average amount of time each of you were searching for jobs on our website? And are you excited to be here? And then I ask them, why is that? Why do people want to be here? And I have joke about, the flowers that we planted this spring out front, aren't they beautiful? And isn't that why people are attracted to working here? And I want them to say it, which is the reason people patients think this place has a great reputation is because of the people who work here. And I want them to understand that we as executives have an enormous responsibility to keep it that way. That if our employees don't enjoy being here, if we haven't figured out how to give them career development, if we're not fair and equitable, if we're not inclusive, if we're not thoughtful about networking, how to make everyone feel like they're part of something so it's not cliquey. If we haven't really taken the time to do that, then I think in many ways we fall short. Because I don't think you can do any of this if you don't have an engaged workforce. And I think to our credit, I think we endured being the epicenter of COVID when it first came in March of 2020 in New York City. I think comparative to other institutions, we fared very well because people feel really good about being here. Look, we took our losses and there are casualties from that pandemic and it will continue to dog us for a number of years. But compared to colleagues I talk to at other hospitals, we have a tremendous amount of employee engagement in spite of it. Whereas I have colleagues from other institutions around the country who've told me they're really struggling keeping people engaged. Forbes just came out with a cover article with a headline that 75% of healthcare workers may leave the industry by 2025. And that's a real consideration that we need to be paying attention to.
Thank you very much. You mentioned earlier about the Board of Trustees.
Mm-hmm.
So I want to make a quick reference to because we'll have a special session in the board on accountability. But this is really a nice illustration of showing how communication all the way to the committee of the board, which I'm a member, and to the full board, the executive committee of the Board of Trustees.
Mm-hmm.
So, as you said, the accountability exists.
Mm-hmm. Big time. Yeah. And as you described here, I mean, we, in a big health system, spread across a big geography, and I'm sure we have colleagues in the webinar from other big health systems. This is how you tie together, I think, the activity, both bidirectionally, the activity that's going on at the Committee on Quality at the board level, and the degree to which they're getting quality information and reviews from the local performance improvement coordinating group at the hospital. And so I think that bidirectional accountability works well. And frankly, certain outcomes at this institution end up on the agenda of the Board of Trustees Committee on Quality, and our executive leaders have to attend that meeting, and essentially it becomes a little bit of a congressional hearing, where we're asked to prepare our responses to an event that may have occurred here or a trend that may be going on here, explain where we are, what we're doing about it, and what I'll call lay folks from the board. You have business leaders on that committee who are not doctors, but have accountability and a fiduciary obligation as members of the Board of Trustees. They challenge and ask questions, and I think I having participated in a number of times, I think we have a really good process around accountability with it. It's certainly much like I try to create accountability within the building. I think our board at the system level uses this as a tool to create.
Thank you.
Okay, so I want to just close out and say thank you, John and Yosef. And when I look at summarizing this up, when I look at the Joint Commission Leadership Standard, I can do a lot of check boxes here. Because in your senior leadership role, you set expectations, plan, set priorities, assess and measure initiatives to improve quality, big picture of community. And you showed how we use data and strategic planning and how we operationalize it. And I think it motivates us here as a leader in this organization.
Absolutely.
And you showed how the improvement methodology is part of the culture here. And then our approach to safety, and we skipped over it a little bit with the programs, but anytime we design a new program, we're doing a failure mode analysis. That's and correct. Getting interdisciplinary input to make sure that new technology, that new program is fitting here and best meeting our community needs. And then we talked about a little bit about the board and the government's role for improving quality and safety. So thank you for illustrating that. And lastly, making sure our people are okay, that we have the right resources at the right time and the right systems to do what we need to do. So I thank you for hitting the mark on the leadership standard and sharing your experience with us today.
It's been wonderful.
So thank you very much.